At this point, we're going to get into the clinical value of the diagnosis of gastroparesis, point, counterpoint. And so, Jay will be here to start off, but this meaningfulness, and then David Kunkel will be by.
Thank you, Ken. So I was asked to give a talk stressing the importance of the diagnosis of gastroparesis. It is a meaningful diagnosis and it has significant management implications as well. I'm not sure I have to spend a lot of time talking about it because many of you take care of these patients are well aware that it is not only a meaningful diagnosis, but a diagnosis that has a tremendous impact on patients. So one of the reasons I became a motility doc as opposed to a therapeutic endoscopist, which was I thought my calling, was because of patients like this. This was one of my first patients with gastroparesis, a 35-year-old nurse with diabetes who had nausea 24 hours a day for 1 year. By the time she came to me, she was vomiting 3 weeks per month, up to 20 times a day, and a 40-pound weight loss. Had been in the hospital 6 times. Unfortunately, she passed away, and this is not her stomach, but this could well be a picture of her stomach had we actually examined. So a picture is worth 1,000 words, and I think this really seals my case about whether this is a meaningful diagnosis or not. But let's go on. What I will talk about is why is it meaningful to patients? Why is it meaningful if you want to improve symptoms? Why is it meaningful if you actually want to cure the disease and stop talking about simply palliating patients' symptoms? And then why is it meaningful if you want to truly understand the disorder? And then as a segue to David, I'm going to talk a little bit about our use of the terms gastroparesis and functional sepsis. Well, it's really, really meaningful to patients, and you can just go on the internet these days and hear these sad stories, typically about young women. Not all the patients are women, the majority of them are, and that's not a mystery that they haven't yet solved. But they're women in the prime of their lives, and their lives have been cut down by what is a devastating and debilitating disorder. All of us have had chronic symptoms of some kinds, at least by the time to my age, and we all had acute pain, and we all had acute nausea. But there is nothing worse than having chronic nausea when there's no relief. So I want to make sure you understand how patients feel when they are complaining of nausea. Remember the time that you felt nauseous after a bad meal or a viral infection. Remember the relief you taken when you threw up. Well, there's no sweeter feeling when the nausea goes away. Unfortunately, the nausea never goes away for these patients. It's meaningful patients because it's a chronic disease. This is a study we did from the consortium. It shows that after a year or so, and these are patients being followed at tertiary medical centers by so-called gastroparesis experts like myself and my colleagues on the consortium. And only about a third of them improved, and they improve only marginally. So these symptoms are relentless and persistent. If we want to improve their symptoms, we need to understand that this is a real disease. As an example, until we did this study, which is shown on this slide, most endocrinologists were very reluctant to treat patients with diabetic gastroparesis aggressively. They felt that they were at risk for hypoglycemia and they couldn't really predict what happens with blood glucose levels. And we did the study as part of the consortium. This was funded actually by the diabetes section of the NIDDK, where we put patients on continuous glucose monitoring and gave them insulin pumps. And only because we diagnosed gastroparesis that we could justify using such aggressive therapy. And I'm not going to go into the details of this. But suffice to say, aggressive insulin therapy helps. There's probably nothing better today than offering very, very strict management of the glucose to diabetic patients. And by doing so, we were able to improve their symptoms dramatically. We were also able to improve the hemoglobin A1Cs. And of course, we were able to help with their quality of life and improve their ability to tolerate the immune system. This is my favorite topic, cure. So here's where we go. We've been sitting here for the last 100 years or so when it comes to gastroparesis. And I'm really tired of telling this to my patients. This cartoon says it all, right? Unfortunately, there's no cure. There's not even a race for cure. Well, there's not going to be a race for cure. There's not going to be a starting gun until we all agree to call it a real disease and recognize that it's a real disease, because people aren't going to take us seriously if we don't. We actually know a lot more about gastroparesis than we did 5 years ago. Thanks to the work of our colleagues in the consortium at the Mayo Clinic, Gasroparesis, and others, we now know the pathological basis of at least a subset of these patients. This is a disease that is characterized by 2 main features. One is the loss of the interstitial cells of Cajal, and we think that is being driven by an aberrant macrophage activation. So I'm not going to go into the pathology slides in detail, but suffice to say that if you look at patients, regardless of whether they have idiopathic or diabetic gastroparesis, there is a significant loss of ICC. And mind you, there is no significant loss of neurons. So this is not a burnt out neuron disease. This is potentially a reversible disease because we know ICCs are plastic and they can be brought back. We also know that the loss of ICC correlates with this macrophage switch from the anti-inflammatory to the pro-inflammatory. We also know that this switch in macrophage actually correlates with gastric emptying, as shown here. So these findings have set the stage for potential curative approaches if we agree that there is an aberrant macrophage-driven inflammatory response. And these are some of the protocols that we are currently actually engaged in. Some that address macrophage activation, such as pioglitazone, which is an anti-diabetic drug, or IVIG. We're also thinking about how to directly stimulate the growth of ICC, either with low-dose growth hormone or with ghrelin agonists, some of which are actually in trials for nausea and improving gastric emptying, but as a side effect, may actually promote ICC growth. And then, of course, what are the trigger factors? One of the surprising findings in our consortium was that 50% or more of our patients were paradoxically obese or overweight. And we think that obesity, which is in fact an inflammatory condition, may be driving gastroparesis in some of these patients. So what's in the name? Well, actually, not much. We took patients who had gastroparesis-like symptoms in our consortium, and if you brought them into a room, you didn't know the results of their gastric emptying, you would swear that they had delayed gastric emptying. It turns out they don't, they have normal emptying. And when you look at the pathology that we did, it is identical to gastroparesis. So we're talking about the same disease. And the issue is not whether gastroparesis is another name for functional dyspepsia in most cases. The reality is that what we are calling functional dyspepsia is actually another name for the gastroparesis family of gastric neuromuscular disorders. And I would like to start calling these gastric neuromuscular disorders in fact. And you can call them type A or type B, depending on whether they have delayed or normal emptying. But for God's sake, stop calling them functional dyspepsia. Stop calling any patient functional. Let's take a vow in Milwaukee today to ban the term functional from our lexicon. It is not respecting our patients. It's not respecting the work we have done as a group to understand the organic basis of these disorders. And it is not giving pharma any hope that these disorders can be cured. Thank you.
Okay, thank you, Jay. And next, David will give another viewpoint.